Good morning. This is a makeup video in which we're going to pursue our discussion of the different heart rhythms that can be seen on an ECG tracing. And today in this video, we are discussing first sinus bradycardia. When we say sinus, this means that the origin is the sinoatrial node. And when we say bradycardia, we mean that there is a slow heart rate, slower than the slowest range of the SA node. So the rate is definitely below 60 beats per minute, and the rhythm is regular. Why is it regular? Because it arises from the sinoatrial node, because it is a sinus rhythm. So all rhythms that arise from the sinoatrial node will be regular, whether they are within the normal range, which is the normal sinus rhythm, or they are higher or faster than normal, which is the sinus tachycardia, or slower than normal, which is this topic we are discussing today, which is sinus bradycardia. Note that the rate indicates the number of times the sinoatrial node generates an electric impulse per unit time. So, and definitely it is the number of heartbeats per unit time, because every time the sinoatrial node will send an electric impulse that will spread over the atrium and the myocardium, there will be a response of the heart in the form of atrial contraction followed by ventricular contraction. So every electric impulse that is being generated is followed by a heartbeat. The rhythm, on the other hand, indicates the regularity. So is the rhythm regular or irregular? Here, because it originates from the sinoatrial node, then it is a regular rhythm. And definitely, since the rate is slow, then the rhythm is also slow. Concerning the P wave, of course, it is normal, because the P wave represents what? It represents the spread of depolarization that is generated from the pacemaker of the heart over the myocardium. So if the pacemaker is the same, if the pacemaker is still the SA node, then the spread of depolarization over the atria will be represented by a normal P wave, as you can see here on the ECG tracing at the bottom of the slide. Similarly, because it is a sinus rhythm, then it is normally transmitted from the atrium to the ventricle across the AV node, and every P wave will be followed by a QRS complex. Why? Because every atrial depolarization will be followed by a ventricular depolarization. Concerning the PR interval, which represents the spread of depolarization or the conduction actually of the wave of depolarization across the AV node with some normal physiological delay, it's 0.12 to 0.20. Here, the PR interval will still be between 0.12 to 0.20. 0.12 means what? 0.12 means 3 small squares, because every small square has a duration of 0.04. So 3 small squares have a total duration of 0.12. 5 small squares have a duration of 0.20. So I mean the small squares that are inside each big square. So here, for example, you can see that there are 3 squares in the PR interval between the end of the P wave and the beginning of the Q wave. Why is the PR interval normal in duration? Because of normal conduction from the atria to the ventricles across the AV node. Moreover, it is consistent, meaning that all the PR intervals between the end of the P wave and the beginning of the QRS complex along the ECG tracing are the same. And this is another evidence that they are transported or carried across the same pathway, which is the AV node. That's why they have the same range of duration and they are consistent, meaning that they have the same duration in all the along the ECG tracing. Again, because the ventricular depolarization occurred normally and the spread of electric activity across the ventricle started at the AV node and spread over the myocardium in the normal direction, then the QRS complex will also be normal in shape and normal in duration. And the normal duration of the QRS complex is when the total duration is less than 0.12 or 12 seconds, of course, or 3 small squares. And now we come to an irregular rhythm, which is called atrial fibrillation. Of course, when we have atrial fibrillation, this is a heart rhythm that does not originate in the sinoatrial node. It originates in a focus in the atrium. That is not the sinoatrial node. It is an abnormal focus or an ectopic focus, ECTOPIC. In such a case, in atrial fibrillation, there is an ectopic focus, an abnormal focus that decided to be the pacemaker because, for example, of cardiac ischemia, the lack of oxygen renders the muscles of the myocardium, the heart muscles around the SA node, a little bit hyperactive, more excitable than normal. So they acquire the property of the SA node to be able to generate electric impulses on its own. So one cardiac muscle all of a sudden started generating electric impulses at a very rapid rate on its own without any extrinsic innervation at a very rapid rate, which is 350 to 600. And since that rate is much higher than that of the SA node, and since that ectopic cardiac muscle or ectopic pacemaker has the ability to generate spontaneous electric impulses on its own, then it will override the rate of the SA node and become the pacemaker of the heart. The generated electric impulses from that atrial focus, because when we say atrial fibrillation, this means that the ectopic focus is in the atria, start spreading over the atria normally and arrive to the ventricles as normal through the atrioventricular node. But if you notice that the ventricular rate, it's true that the ventricular rate is higher than normal, it's higher than 100, which is similar to tachycardia, but it's not true tachycardia, and I'll be saying why. But the impulses have passed from the atria to the ventricles across the AV node normally. Why? Despite the presence of an ectopic focus, because the focus is in the atria. So in order to pass to the ventricles, it has to pass through the AV node. It does not have another pathway to pass through. So what happens is that the impulses pass from the atrium to the ventricle, but there is a diminution of the heart rate. For example, if the atrial rate is 300 and the ventricular rate is 100, then there was a 3-to-1 block, meaning that it's only 1/3 of the waves that arrive to the ventricles, and this is the role of the AV node. So in atrial fibrillation, the AV node delay protects the ventricles even when there is an ectopic focus and even when the rate is very high in the atria. But the main problem with atrial fibrillation is not only the very rapid rate of the new ectopic pacemaker, but it is the irregularity of firing an electric impulse. So the rate is irregular, is very variable. It's not only irregular, but it is irregularly irregular, meaning that in some areas of the ECG strip, you might find the heart rate, for example, 150 beats per minute. And then in another part, you might find that the rate is 200 beats per minute, and so on. And then it slows down. But the overall rate is 350 per minute. This is what we mean by irregularly irregular. This is the normal cardiac tracing, and this is the abnormal irregularly irregular ECG tracing that we see in atrial fib or in atrial fibrillation. When you look at the P waves in between the QRS complexes, you can not distinguish a well-defined P wave, neither, of course, a T wave. Where has the T wave gone? It has been masked by the many irregular P waves that you can see. And that's why we say that the P waves are chaotic, and they are irregularly chaotic because the ectopic focus fires in different directions every time. And the wave of depolarization is not organized, and therefore the depolarization waves cannot sum up to form a well-defined P wave. So you have small waves of depolarization that do not sum up together and that do not form the regular P wave. So in order to find the regular positive small P wave, upright P wave that we see in a normal ECG tracing, we should have the waves of depolarization all arising from the sinoatrial node and at the same time so that they can sum up. Because of these chaotic, irregularly irregular P waves in between the RR peaks, then we can say that there is no baseline. For example, here, in between the T wave and the next P wave, you have a straight line that is at the level of 0 amplitude or 0 millivolt. We call this the isoelectric baseline. The isoelectric baseline is the baseline at which the value on the y-axis of the amplitude is 0. But here we cannot find an isoelectric baseline between the waves because the waves are very small, very close to each other, leaving no isoelectric lines between them. The QRS complexes are usually, as we said before, the duration should be normal, less than 0.12 seconds or less than 120 milliseconds. It's the same value, 0.12 second and 120 millisecond. So by this, we mean that the QRS complexes are normal in shape, narrow as usual, having a normal amplitude, unless there is a concomitant or a pre-existing bundle branch block. What do we mean by bundle branch block? When we go back to the diagram of the transverse, the longitudinal section in the heart, like this one, for example, we will find that I don't know if we have a picture of the conduction system of the heart, but imagine that here we have the SA node and here we have the AV node. Then there are very specialized cardiac muscles that are present in the interventricular septum and that branch, they make a U-turn like this and branch into a left branch and a right branch. Because these highly specialized cardiac muscles that are also very rapidly transferring of electric impulses, because they divide into two branches, so we call this branch the right bundle branch, and we call the other branch the left bundle branch. They're nothing but specialized cardiac muscles inside the myocardium that allow the electric impulse received by the AV node after the AV nodal delay to move very rapidly across the interventricular septum. And then very rapidly across its two branches. The aim, of course, is to make the two ventricles contract at the same time to increase the efficiency of heart beating. But sometimes one of the bundles is diseased, one of the branches is diseased. So if it is the right branch that is diseased, we call this a right bundle branch block. And if it is the left branch that is diseased, we call this the left bundle branch block. Why do we call it a block? Because when it is diseased, it will result in slower conduction. So if both branches of myocardium, specialized myocardium, spread rapidly, we will have the normal shape of the QRS complex. But if the wave of depolarization spreads on the right side normally, but spreads onto the left side slowly, then the QRS complex will take a longer duration. The width of the QRS complex will take a longer period of time to finalize spread of depolarization over the ventricles, and this simply means that it will be broader. A wider or a broader ECG means that it took a longer period of time. Then we move on to atrial flutter. Atrial flutter is less serious than atrial fibrillation. Why? Because in atrial flutter, there is a regular pulse, number one, and the rate is usually slower. In atrial fibrillation, the ectopic focus could beat at a very rapid rate that might reach 600, but in atrial flutter, the maximum rate is 300 beats per minute. Again, atrial flutter is a non-sinus rhythm. It does not arise from the sinoatrial node. It arises from an ectopic focus. What about the ventricular rate? It will depend upon the delay in the AV node. And this is what we call the AV conduction ratio. By AV conduction ratio, we mean the ratio between the atrial rate, which is 300, and the ventricular rate, which might be, for example, 150. This ratio indicates you that the AV conduction delay has halved the 300 into 150, has caused a diminution of the number of waves per minute reaching the ventricles from 300 beats per minute generated in the atria to 150 reaching the ventricles. This means what? That out of every 2 waves of depolarization that spread over the atrial muscles, we have only 1 wave that reaches the ventricles, and this means that we have a 2-to-1 AV conduction ratio due to what? Due to the AV conduction delay. And therefore, when you look at the QRS complex, you will find that supposedly in this example, you should have 2 P waves, 1, 2, followed by a QRS complex. But here the ECG tracing that you have on the diagram does not match with the text. It is, of course, atrial flutter because we have more P waves than the QRS complex. But if we consider this small wave just after the QRS complex, a T wave, then you have 3 P waves before 1 QRS complex. This means that if the atrial rate is 300, then the ventricular rate would be 100. And this means that we have a 3-to-1 block due to the AV nodal delay, meaning that out of every 3 waves of depolarization that spread over the atria, only 1 of them passes to the ventricles. And of course, if you want to see the atrial rate, look at the number of small squares between two successive P waves. You have one large square or five small squares. So if we consider the five small squares as one big square, then in order to calculate the rate, we would divide 300 by 1, which is the number of big waves, and it is 300. But so the atrial rate, according to this, is 300. But if you look here at the ventricular rate, let's look here at the RR interval, we have two complete large boxes at least, and one small box. Let's consider them two big boxes. So the ventricular rate is supposedly 300 divided by 2, which is supposed to be 150. So there is something strange about this ECG, because if the atrial rate is 300 and the ventricular rate is 150, then the conduction block, or the AV conduction ratio is 300 divided by 150, which is 2 to 1, but we have actually 3 P waves before the QRS complex. Maybe we haven't calculated the atrial rate adequately. Now, the QRS complexes should be normal in shape and normal in duration. Again, why? Because they are conducted normally across the AV node. And there is, of course, again, this is the second type of arrhythmias where we find a loss of the isoelectric baseline, because we have multiple P waves on the horizontal line, and they mask the isoelectric line. There is no possibility to see an isoelectric line. But here, this is different from atrial fibrillation, because the P waves are not chaotic. They're all similar to each other. They are visible. They are easily detected, but they give us the sawtooth pattern. And the sawtooth pattern is resulting from the flutter waves. These waves resemble the P waves, but they are not exactly similar to the regular and normal P waves. Now, ventricular flutter, of course, any of these rapid rates, especially atrial fibrillation, which is rapid and irregular at the same time, is very serious, because when you have a high ventricular rate, as I said before, any increase in the heart rate, whether it is a regular sinus tachycardia or a regular atrial flutter from an ectopic focus, or an irregular atrial fibrillation, whatever the cause of increased heart rate is, this occurs at the expense of diastole, meaning that there will be a shorter period of relaxation of the heart, and the heart will not have enough time to fill with blood during diastole, and therefore this will result in less blood being pumped into the aorta, and less oxygen reaches the tissues per unit time. The tachycardias, or the rapid heart rates that are arising from the ventricles, are much more serious. So, of course, we have ventricular tachycardia, but I didn't get it. I might include it later on, but I included only the ones that are really serious. This is ventricular flutter. What do we mean by ventricular flutter? We mean that the rate occurs, the heartbeat originates in the ventricle. What does this mean? This means that the ectopic focus is in the ventricle. As I said before, this happens only when there is a serious organic disease to the heart, like ischemia or relative insufficiency of the blood supply, and therefore of the oxygen supply to the myocardium. Of course, the more severe the ischemia is, the more the likelihood of the flutter being or originating from the ventricles rather than originating from the atria. So if you have a mild ischemia, a mild insufficiency of blood supply to the heart, you might have an atrial flutter. But if it is more severe, you would have ventricular flutter, in which the ectopic focus is in the ventricle. And this is catastrophical. Why? Because when the ectopic mad focus that appeared all of a sudden or emerged all of a sudden in the atria appears, the ventricles are protected by the AV node. But look at this condition when the mad focus that decides to be the pacemaker is not in the atria but in the ventricles. There is nothing at that time to protect the ventricles. How could the AV node protect the ventricles? So in ventricular flutter, the rate is usually between 250 to 300 beats per minute. And this is a rate that's higher than the rate of the SA node, of course. And the cause, as I said, is ischemic heart disease. And because the origin is in the ventricles, so from an ectopic focus that might be on the right side or on the left ventricle, you can never know. But it is an abnormal ectopic focus. And by ectopic, we don't only mean that it is abnormal, but ectopic rather means that it is besides or in a position that is not the normal position. So ectopic is something that is not at the normal position. So here we have this very, whatever or wherever the ventricular ectopic focus is, we will have this very characteristic shape of the QRS complexes that we say sinusoidal. It's similar to the sinusoidal curves that you study in calculus, for example. You might be asking, what about the atria? Aren't the atria contracting? Aren't the atria depolarizing? Yes, they are. And they might be depolarizing at the sinoatrial rate, 60 to 90 beats per minute. And there will be a complete dissociation between the activity of the atria and the activity of the ventricles, meaning that if there was a possibility for the P wave to appear here, it should be completely dissociated from the QRS complex. It wouldn't follow the golden rule that every QRS complex should be preceded by a P wave. Why am I saying if it were to appear here? Because it will never appear. Why wouldn't be never shown on the ECG tracing? It's just because the P waves are slower and slower in rate than the QRS complexes. And most importantly, that the amplitude of the QRS complexes that are not only having a larger amplitude or a higher amplitude, but also a broader width or duration. So they mask the P waves completely. Any electrical activity that is related to the atria will never appear here because these broad sinusoidal and rapid, they're broad, sinusoidal, and rapid. They are masking completely any atrial activity, of course, including the wave of depolarization. Does it have hemodynamic effects on the body? Of course, yes, the same. Since we have a heart rate that is rapid, independently of whether it is arising from the atria or from the ventricles, it will, of course, diminish the blood pressure and diminish the perfusion of the tissues with blood and oxygen. But again, I emphasize that rapid heart rates from the ventricles are more serious because they might be too rapid, and at the same time, there is no protection from the atrioventricular node. And then we would study afterward ventricular fibrillation. And this is the most serious arrhythmia that might affect a person. And most of the time, ventricular fibrillation is a fatal arrhythmia unless the patient is in a hospital, unless the patient is rescued on the spot unless the patient is in the intensive care unit, and we use devices for defibrillation or resetting of the heart rate to the original sinus rhythm. And of course, this does not always succeed. Of course, since it's called a ventricular fibrillation, then again, it is a rhythm that arises from an ectopic focus in the ventricles. So it's more serious than atrial fibrillation. And because it is fibrillation, then similarly to atrial fibrillation, it will be irregular, not only irregular, but irregularly irregular and very rapid. As you can see here, you do not see the normal classic ECG tracing with a P wave, a QRS complex, and a T wave. You just can see irregular electrical activity that is more or less similar to the QRS complexes, but of course, you cannot see P waves, you cannot see T waves, they are completely masked, as we said before. And the P wave is masked because atrial activity is masked. The wave of repolarization cannot be of the ventricles, which is the T wave cannot be distinguished from the electrical activity of depolarization. Of course, the QRS complexes are chaotic. They are very broad. They are sometimes bifid, as you can see here. They are irregularly irregular. The rate is very rapid. In such cases, of course, you can, as I said at the beginning, you can never use the distance between two successive R waves, I mean the RR interval, to calculate the heart rate, because the RR intervals are unequal because it is an irregular heart rhythm. In such a case, you have to calculate, to count this is how we calculate the heart rate in an irregular heart rhythm. As I said before, each small square duration is 0.4 second. So the 5 squares, which form the big square, is 0.2 second. So every 5 big squares will form 1 second. So if I need 30 seconds, then we have to multiply 5 squares by 6, which is 30. So you count 30 big squares, and usually the ECG paper, tracing paper, is marked at the beginning and at the end of 30 squares. What do 30 big squares represent? They represent 30 by 0.2. So the 30, we said that one big square represents 0.2 and 5 big squares represent 1 second. So 30 big squares will represent 6 seconds. So if you count the number of QRS complexes that cover 60 or over 60 30 big squares, this represents 6 seconds. If you multiply again by 10, then this will represent 60 seconds, which is 1 minute. So let's count the number of big squares here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23. They are neither 15 nor 30. So actually, let's suppose they are 30, or let's calculate it accurately. Let's say that we have 23 squares, big squares. How many waves do we have here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. And then we multiply 20 by 30 over 23 in order to obtain the number of waves in 30 big squares. And this represents 6 seconds, and we will multiply by 10 to get the ratio. We will do this in class once again, but you had better do it, for example, on ventricular flutter, because Here we can have, here this is a better example. Why is it a better example? First of all, because the QRS complexes are well defined. And second, because you see the marks here, 5 squares. Look, 1, 2, 3, 4, 5. So every 2 successive marks include 5 big squares. So here we have 1, 2, 3, 4, 5, 6. So these are 30 big squares. 30 big squares represent 6 seconds, as we said. And then we count the number of QRS complexes, which is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So you have 30 QRS complexes per 30 big squares, which means 30 QRS complexes per 6 seconds, which means 300 per 60 seconds, which means 300 per minute. So the rate is 300 per minute, and this is how we calculate the heart rate when we have an irregular heart rhythm. The last ECG tracing that we will be discussing is the AV nodal rhythm. The AV nodal rhythm means what? That the SA node has been slowed down by a disease and like ischemia, and that the AV node is taking over. Therefore, the AV node will generate electric impulses, and these electric impulses will be spread upward to the atria and downward to the ventricles at a very slow rate, which is 40 to 60 beats per minute. It's a regular heart rate, but very slow heart rate. What about, so here you can see how many big squares are there between two RR waves. 1, 2, 3, or between in the RR interval, 1, 2, 3, 4, 5, 6, 7. If you divide 300 by 7, this gives you 40 something. So it is about 45, for example, beats per minute. The second, and of course it's obvious, once your eyes get trained on the normal heart rate, then you can definitely deduce, once you see that ECG tracing, that although it is a very regular rhythm, yet it is a very slow rhythm. But the other characteristic that you can see is that the P wave is inverted. What does this mean? This means that the wave of depolarization spread. What does the P wave represent essentially? It represents the spread of the wave of depolarization over the atria. So when the wave of depolarization came from the SA node, it came from above downward. But this time it arose from the AV node and moved upward in the opposite direction towards the SA node to spread over the myocardium. And that's why the P wave is inverted. So why is the P wave inverted? Because the wave of depolarization originates from the AV node and spreads from below upward over the myocardium. Why are the QRS complexes normal? Because they are normally transmitted via the AV node and then through the AV bundle and then through the bundle branches. Why are the PR intervals so short? They are very short or even missing. Look here, there is almost no PR interval between the end of the P wave and the beginning of the QRS complex. This is because, as you can see, as you might have understood, that the origin is at the AV node. So in order for the impulse to pass from the AV node to the ventricles, it passes in no time. And that's why the PR intervals are very short or even missing. Thank you guys. I'll be receiving a worksheet on those ECG tracings that we have just discussed.